Good afternoon. I'm Catherine Santoro, Director of Policy and Development at the National Institute for Healthcare Management Foundation, and on behalf of the NIHCM Foundation, welcome to our webinar today. Every year, more than 2 million Americans become infected with some form of antibiotic-resistant bacteria, and the CDC recently reported that nightmare bacteria, those with unusual resistance to antibiotics, were found more than 200 times in the U.S. last year, adding a renewed sense of urgency to this growing public health crisis. To explore strategies to address the growing superbug threat, we're pleased to have a prestigious panel of experts with us today. Before we hear from them, I'd like to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM staff who helped to convene this event today, including Kate Ellis, Katie McDonald, Carolyn Myers, and Kirsten Wade. You can find biographical information for all of our speakers, along with today's agenda and copies of slides on our website. We also invite you to live tweet during the webinar today using the hashtag #antibioticresistance. I'm now pleased to introduce our first speaker, Dr. Alexander Kallen, the Chief of the Prevention and Response Branch in the Division of Healthcare Quality Promotion at the Centers for Disease Control and Prevention. Dr. Kallen is one of the authors of the recent CDC Vital Signs report on unusual resistance, and we're so grateful he's able to join us today to discuss this report and the CDC's containment strategy. Dr. Kallen?
Great, thanks very much. Hi, everyone. Great to be with you this afternoon. I'm just going to spend a few minutes talking about the new response to, or the new strategy to responding to these kind of unusual resistance phenotypes that are showing up more and more in the United States that was highlighted in the recent CDC Vital Signs. So I'd like to start with the story of what can happen if we are not aggressive about responding to these types of bacteria. And this paper, which came out in the year 2001, highlights a new form of resistance that was identified from an isolate collected in 1996 in North Carolina during a CDC project to look at resistance in intensive care units. And it was highly resistant to lots of different antimicrobials, and had so much resistance that it actually underwent some kind of special analysis to detect what was the mechanism behind it. And what they detected was a new carbapenemase. This is an enzyme that breaks down lots of different antibiotics, making them not effective. And this was the first time a carbapenemase was identified in the United States, and it continues to be the carbapenemase that's the biggest problem in the United States, and it is called KPC, or Klebsiella pneumoniae carbapenemase. This enzyme creates these bacteria that you've heard so much about called CRE, or carbapenem-resistant Enterobacteriaceae, that our former director, Dr. Frieden, coined the nightmare bacteria. So the next slide shows kind of what the picture looks like as far as reports to CDC of these bacteria, starting in 2001 when the report came out, and then 16 or 17 years later in 2017. And I think what you can see is kind of a slow but steady spread across the United States, starting in the East Coast, moving to the West Coast, and then kind of filling in the middle. And actually, today that map is completely filled in, even with Idaho reporting at least one case of KPC-producing CRE. And I think this illustrates what can happen when we use our kind of usual strategy to responding to antibiotic resistance, this kind of siloed approach that's been what has been employed in when most of these resistant bacteria have kind of emerged. In 2017, CDC rolled out a new strategy, which is being called Containment, and it's designed to address these emerging threats as were described at the opening, that are being found more commonly in the United States over the last few years. This Vital Signs report is an opportunity for different divisions in CDC to highlight some of the important topics that they're working on, and our division has done one a year for the last few years, and on such topics as central line-associated bloodstream infection prevention, antibiotic stewardship, and CRE, or carbapenem-resistant Enterobacteriaceae. This approach is really kind of based on a pretty simple idea, and that's that once antibiotic spreads and becomes common in the country, it's very hard to control, and it's much more efficient and effective to respond early when this resistance is first identified and before it can become common. The main points in this strategy is that makes it different from kind of the normal approach is that, first of all, it's designed to be based on, to be implemented with the detection of a single isolate. So historically, when these isolates are detected in healthcare settings, often, not much is done to look for other cases or to intervene other than the routine things that might normally be done when a resistance pathogen is detected, unless there's an outbreak or a cluster. And so this response is designed to act even at the presence of a single case. The other thing that's kind of interesting is historically when we look back at the way we've approached resistance, we've often approached based on what's called a phenotype, so an antibiotic susceptibility pattern. Many people, if you know methicillin-resistant Staph aureus or MRSA or vancomycin-resistant Enterococcus, all important MDROs, but those were primarily based on a phenotype, a drug susceptibility pattern. But what we've learned over the years, especially with the gram-negative bacteria like CRE and Acinetobacter and Pseudomonas, is that often the underlying mechanism is also important. But we haven't historically had ways to delve down that deep to figure out what the mechanism is to be able to respond to these differentially. And so this response now enables us to do that. Some of the bacteria and fungi that are being targeted by this approach are shown on this slide and include the CRE that we've been talking about, but particularly the ones that produce a carbapenemase like KPC, which is what I mentioned at the beginning. Carbapenemase producing Acinetobacter and Pseudomonas. This new highly resistant yeast called Candida auris, and also pan-resistant strains, or strains of bacteria that are resistant to all known antibiotics that we have available to treat them. A fortunately very uncommon event here in the U.S. The containment strategy has 5 different pieces to it. The first, and perhaps most important, is to be able to detect these isolates when they appear. So without knowing that they're there, it's hard to respond. The second is infection control assessments led by health departments to actually make sure that the appropriate infection control practices are in place to prevent transmission. Colonization screenings. This is important because many of these bacteria only cause disease in a very small minority of people, but these other people who have the bacteria on their body without symptoms are called colonized, and these colonized patients can serve as a source of transmission as they are not usually recognized and the appropriate precautions are not put in place. The next is coordination between healthcare facilities. As I described the outbreak of CRE originally in the United States, the KPCs in the first few slides, that was using a very siloed approach where different facilities did their own thing, and this coordinated approach allows us to be more aggressive and work between facilities to help control the spread, and lastly, continued vigilance until the spread is controlled. In order to detect resistance, CDC has put in place a very exciting new program called the Antibiotic Resistance Laboratory Network. It has 2 pieces. One, it's state and local health departments that actually can do specialized testing to look for these specific mechanisms, and the second is the 7 regional labs across the country that actually can do testing for looking for these patients that might be colonized and not otherwise detected. In addition to that, CDC sponsors more than all or part of 500 different staff in state and local health departments across the United States that are working on these issues, as well as 35 programs in 35 different states or local health departments in order to address these problems locally, and a large number of projects via our Prevention Epicenters program to look for novel ways to prevent transmission of these pathogens. So just as highlighted in the MMWR that I mentioned, the vital signs, between January and September 2017, nearly 6,000 isolates were tested, and 25%, sorry for the typo there, 25% were actually these highly resistant carbapenemase-producing strains that wouldn't have been detected without this testing. As part of that, there were 70 responses, including almost 1,500 screening tests 11% of screened patients were positive, and these again are people that probably wouldn't have been detected without this testing, and were able to be, and the appropriate precautions were able to be put in place. In addition, this has helped us identify higher risk facilities, healthcare facilities where amplification or greater spread is happening, to be able to target these facilities to slow transmission. Just to give you kind of an illustrated example of what a containment approach looks like, one that was highlighted in the MMWR, includes this one where the health department was notified of a patient who had one of these unusual resistant CRE, produced an enzyme called IMP, which is rarely seen in the United States. The health department went to the facility, assessed the infection control interventions, and actually did a survey of the patients, the contacts there, the residents that were contacts, and found 5 additional cases. The Department of Health then conducted additional infection control assessments and additional point prevalence surveys until 2 follow-up surveys didn't show any additional transmission. So kind of in a very aggressive and exciting way to prevent transmission that is having effects nationwide. How do we know that? A couple of things, a couple of ways. One, which was highlighted in the MMWR, is these data here. And what it shows on the left-hand box is what happened with a type of resistant gram-negative called ESBLs that kind of predated the CRE and was kind of the original resistant gram-negative before CRE. And as you can see, when these emerged in the 1980s and 90s, there was kind of the response as usual, and this kind of shows what's happened to those bugs between 2006 and 2015, and I think you can see there's a slight decrease there, but it's remained relatively stable. CRE, the bacteria that we've been talking about since the beginning, however, that emerged here in the United States about in 2001, had a more aggressive response, with including specific guidance in 2009 that specifically addressed and targeted these pathogens. And the good news there is that the percent of healthcare-associated infections that are caused by CRE have decreased from about 10 or 11% in 2007-8 down to about 3 or 4% in 2015. Lastly, we're able to do some kind of very sophisticated modeling to look at what this type of the effect that this type of response might have over time. And what this shows is that based on our mathematical modeling, that if we didn't do anything and we kind of let these things continue, the red line is what we would see as far as transmissions per day, and I think you can easily see that by the end of this, there's about 40 or so transmissions a day. If, however, we use this containment approach and had an intervention that was only 5% effective, so not hard to believe that that could be achieved, we can cut that number of transmissions today by about 50% to about 20, and then if an intervention shown in green is about 20% effective, we can actually cut that down to very low numbers, and again, all very achievable numbers. I want to finish up just with some thoughts about what people can do. Obviously, for this to work, it's going to take work from everybody, CDC, healthcare facilities, clinical labs, et cetera. I encourage you to look at the MMWR if you want more details, but just refreshing, just highlighting a few of the top level things that, it's important that healthcare facilities think about that these pathogens can show up at your door and think about ways to address them. It's important to work with the health department to make sure that you're sending the isolates that are important to the health department for testing, and that you're working with them to ensure that infection control interventions are in place when they're identified. It's important to remember that these patients need to be put in the appropriate precautions when identified. It's important to communicate the status of these patients when they're transferred to a higher or lower level of care. And it's important to also look for these patients when they first the patients at higher risk when they first show up at your facility, and most often that's patients who have had recent travel or health care outside the United States. So thanks for your attention, and I'll hand it back to Catherine.
Thank you so much for your leadership and CDC's leadership on this, and for those recommendations for how our audience today can help support your work. There's many excellent resources and information on the CDC's website, so we encourage everyone to check that out. Our next speaker is Dr. Dmitri Iarikov, the Acting Deputy Director in the Division of Anti-Infective Products the Center for Drug Evaluation and Research at the Food and Drug Administration. The FDA is leading a variety of approaches to encourage the development of new antibiotics, and we're so pleased to have him with us today to share some of this work.
Hello, everyone. Good afternoon, and thank you for joining us. As you know, the decline in antibacterial drug research and development, a serious antibacterial drug-resistant infection increase is a critical public health and patient care concern. And today we're going to talk about FDA approaches to facilitate antibacterial drug development for patients with unmet medical need. I'm going to describe challenges in developing drugs to address antimicrobial resistance and then discuss FDA approaches to facilitate antibacterial drug development. One of the reasons for decline in antibacterial drug development is that conducting clinical trials to evaluate antibacterial drugs for the treatment of patients with a serious bacterial disease caused by resistant pathogens is challenging for a number of reasons. First, these trials are difficult to enroll because patients are often critically ill and delays in treatment related to enrollment procedures may not be acceptable. Then there's a diagnostic uncertainty with regard to the index infectious disease and its bacterial etiology. Plus, multiple study sites need to be recruited as the cases of resistant infections may be spread geographically and occur infrequently. As a result, the interpretation of the results of trials in resistant infections can be challenging. The sample size of trials in patients with these infections are commonly small. Mortality and morbidity related to underlying comorbidities may confound efficacy and safety assessments, and prime potentially active antibacterial therapy may obscure the effect of the antibacterial drug under study. There are also financial disincentives to develop drugs against resistant pathogens. Population in need may be relatively small. Antibacterial drugs are prescribed in general for a short duration. In addition, development of resistance and antimicrobial stewardship efforts may limit the use of the drug. Also, the use of the drug, if approved, may be limited by non-availability of antimicrobial susceptibility testing at the time of approval, because testing devices are developed by companies independent from the drug developer. Given the challenges associated with the development of antibacterial drugs for treatment of serious bacterial diseases, FDA has been implementing several regulatory approaches to accelerate antibacterial drug development, including expedited development programs, qualified infectious disease product designations, streamlined unmet need development programs, and limited population antibacterial and antifungal drugs approval pathway. I'm going to briefly describe these approaches. My apologies for some wordy slide. All four expedited programs represent efforts to address an unmet medical need in the treatment of a serious condition. These programs offer several incentives to drug developers, including more frequent interactions with FDA, and some of the programs offer a shorter review clock, and notably, a drug may be eligible for more than one expedited program. I have to say that the accelerated approval pathway, which is based on a surrogate endpoint, is not commonly used in the development programs of antibacterial and antifungal drugs, and because clinical outcomes can be readily measured in these conditions. QIDP designation. For a drug product to be designated a QIDP, the drug developer should demonstrate that the drug is an antibacterial or antifungal drug for human use intended to treat serious or life-threatening infections, and the designations offer quite a few incentives. It provides additional 5 years of marketing exclusivity. It grants priority review for the first application for this drug for QIDP, and it makes the drug eligible for fast-track designation. And the request can be sent at any time of the development cycle before submission of the marketing application, including a pre-IND stage. Now I'm going to talk about unmet need development programs. As compared to standard development programs, unmet need programs may allow a greater degree of uncertainty in the efficacy and safety of the drug, as they are focused on conditions whose treatment or diagnosis is not addressed adequately by available therapy. An unmet need includes a longer-term need for society, for instance, development of resistance to antibacterial drugs, or a more immediate need for a defined population, for instance, a serious infection with no or limited treatment options. For the drug developed or for the unmet need population, a smaller trials and smaller size of the development program will be considered acceptable. The approval of the drug may be based on the single well-controlled trials supported by evidence from animal and laboratory studies, but risks and benefits will be then communicated in the labeling of the drug. Different approaches can be used to evaluate an antibacterial drug developed for an unmet medical need population, including non-inferiority and superiority clinical trials. These approaches are outlined in the FDA guidance, and the most common approach has been a single non-inferiority trial at the body site of infection, for instance, urinary tract infection, with supportive evidence from in vitro and animal models. One of the recently approved beta-lactam/beta-lactamase inhibitor combination, mirapen and ivermectin, was approved based on the results of a single trial in complicated urinary tract infection. Approval of another beta-lactam/beta-lactamase inhibitor combination, ceftazidime and ivermectin, for treatment of intra-abdominal and urinary tract infection was based on the results of 2 phase 2 trials, one for each indication, and also relied on previous findings of the efficacy and safety of ceftazidime, whereas the contribution of beta-lactamase inhibitor ivermectin was primarily established in vitro and in animal models. And these examples are to demonstrate flexibility and openness in thinking of the agency when dealing with such a serious problem as antimicrobial drug resistance. We have learned several lessons since the implementation of unmet need programs. First, the suitability of a drug for these streamlined development programs need to be considered. In general, candidates for an unmet need program should be drugs that are likely to have a new mechanism of action, or an edit inhibitor that neutralizes a mechanism of resistance, or offers an alteration in the structure that makes the drug no longer susceptible to the mechanism of resistance or improve its safety. And then I have to say that the drug that has slightly greater potency or offer no significant safety advantages is generally not a good candidate for an unmet need medical program. It has to be said that pharmacokinetics of drugs in the unmet need population may differ from that in less sick patients, and efficacy and safety data collected in less sick patients may not always be extrapolated to a more severely ill unmet medical need population. We also noted that trials in patients with infections due to organisms of a specific resistance phenotype, for instance, carbapenemase resistance, Enterobacteriaceae, are challenging to enroll, and some development programs included a small descriptive study in patients with HIV, and without having no pre-specified analysis, and it made interpretation of study results extremely difficult. In addition, with expedited clinical development programs, chemistry, manufacturing, and controlled aspects of the program often lag behind, which may delay the approval of the needed drug. Another regulatory approach designed to help accelerate drug development is a limited population pathway for antibacterial and antifungal drugs, also known as the LPAC pathway. The pathway is established by the 21st Century Cure Act, which was signed into law on December 13, 2016. The act also includes other sections on antimicrobial susceptibility testing and antimicrobial stewardship. And the drugs eligible for the LPAC pathway are intended to treat a series of life-threatening infections in a limited population of patients with unmet needs. Importantly, statutory standards for drug approval should be met under LPAC, and the labeling of products approved under this pathway will indicate that safety and effectiveness have only been demonstrated in a limited population. In addition to regulatory approaches, FDA has implemented several scientific approaches to facilitate antibacterial drug development, including establishing antimicrobial susceptibility test interpretive criteria and creation of AHC criteria website, facilitation of coordinated development of antimicrobial drugs and AHC devices, publishing guidances on drug development for specific indications. Recently, Office of Antimicrobial Products has initiated research efforts. FDA convened several public meetings on antibacterial drug development, and we're actively collaborating with other regulatory authorities. This is I'm afraid it's quite a busy slide, but this is a screenshot of susceptibility test interpretive criteria website that was launched recently, and from now on, data on susceptibility interpretive criteria would be placed on this website instead of package inserts. These slides will address challenges in providing appropriate susceptibility information for patient care. There have been considerable delays between drug labeling updates and device updates, and in addition, there might be need for interpretive criteria for pathogens not listed in the indication sections of drug labeling. So all these problems resulted in in efforts to accelerate coordinated development of antimicrobial drugs and devices for antimicrobial susceptibility testing. A public workshop was convened, guidance on coordinated development of antimicrobial drugs and antimicrobial susceptibility testing devices has been drafted, and drug office and device office of the FDA have participated in several joint meetings with drug device manufacturers to devise potential developmental approaches. We've published several guidances, and this slide is to illustrate our efforts. It's more for reference. I'm not going to dwell on each guidance, but you might see that over the last couple of years there have been quite a few guidance documents published by the FDA. We launched several research projects, and through broad agency announcements, including the development of automated and sustainable electronic approach for data mining to evaluate clinical outcomes of patients with bacterial infections with the focus on drug-resistant infections. We work on evaluation of measurement properties of patient-reported outcome instruments in patients with several infections. And we're trying to bridge novel lab animal and hollow fiber infection models to evaluate central nervous system penetration of drug in infants. We have research contracts for animal models of infections, and research proposals to address antibacterial drug resistance are evaluated on an ongoing basis throughout the fiscal year. And this is a website where our research activities can be sought and studied, and the website provides needed information for those who are interested. This slide provides information on FDA public meetings dedicated to development of drugs targeting resistant infections. And there are quite a few additional efforts that FDA is trying to make to facilitate development of antibacterial drugs. We collaborate with several initiatives and consortiums, and on improvement to trial effectiveness, developing trial endpoints, and also on broad issues related to challenges in antibacterial drug development. And I would like to conclude that FDA recognizes that despite all efforts to accelerate antibacterial drug development, challenges remain, and we're committed to using the tools at our disposal to help encourage the development of safe and effective drugs for serious bacterial and fungal diseases to address unmet needs of patients. And this is the list of recently approved antibacterial drugs over the last 5 years. There have been quite a few drugs approved recently, and some of them target resistant infections. And this concludes my presentation, and thank you.
Thank you so much for sharing all of the important efforts out of the FDA. And we'll now turn to hear from Monika Schneider, a research associate within the Biomedical Innovation Team at the Duke-Margolis Center for Health Policy. And she joins us today to share their work on incentives for antimicrobial product development. Monika?
Great, thank you. I'm really pleased to be a part of this discussion today. I will be covering some of the economic strategies that can be used to incentivize antimicrobial drug development. So bacterial resistance to antibiotics is driven in part by overuse and inappropriate use of these drugs. In the U.S., we spend a lot of money on a lot of antibiotic prescriptions, but about a third of those are unnecessary. Any use of antibiotics can drive resistance, and inappropriate use unnecessarily decreases the effectiveness of these drugs. So antimicrobial resistant infections also significantly drive up healthcare costs during an episode of infection. So novel antibiotics are needed to treat these infections and bring down this cost. Unfortunately, there are currently less than 50 antimicrobial drug candidates in development, and of these, there are very few that can eliminate high-priority drug-resistant infections. As was touched on by Dmitri just in the previous presentation, the reason for this lack of development is largely financial. Companies who develop antibiotics receive a very low return on investment relative to the public health benefits that are provided by these drugs. Several issues contribute to low return on investment. First, clinical development for these drugs can be very costly, especially if they're designed for a limited patient population, like those who acquire drug-resistant infections. Second, a lack of rapid diagnostics to detect infections can mean that enrolling enough patients in a clinical trial can take longer and be more costly. And then once a novel antibiotic is approved, it will generally be kept on the shelf until it is really needed, and that is usually when resistance develops to the standard of care. So this is considered good stewardship practice. We don't want to have to use these novel drugs right away because using them means that the bacteria will have a chance to develop resistance as well. However, the low volume of use means that manufacturers will make very little money off of these drugs, even if they charge a high price for use. And then finally, the health benefits that accrue to non-antibiotic users are not represented in the price of the drug. The lack of antibiotics is a global concern, and there have been several international organizations who have been exploring ways to better incentivize innovative antimicrobial development. And these include the Chatham House, Review on Antimicrobial Resistance out of the UK, the German Global Union for Antibiotics Research and Development, and the European group DRIVE-AB. And while there's some specifics, while the specifics vary in each of these reports, there's been a convergence on several key principles. First, there needs to be an increase in funding dedicated to basic and translational research on antimicrobials. Second, there needs to be some sort of incentive mechanism that is provided once an antibiotic has been approved that will delink reimbursement from sales volume. And finally, there needs to be a global effort to coordinate on surveillance, stewardship, and development. The U.S. has also been making efforts to address this problem. In 2012, Congress passed the Generating Antibiotic Incentives Now, or the GAIN Act, which grants additional market exclusivity to qualified infectious disease products. Over the past 6 years, there have been more than 140 drug candidates that have qualified for this program, and only 12 drugs have actually received approval. One of the limits of this incentive is that it does not address the issue of low-volume sales. So if an antibiotic is not sold in high numbers, then the additional years of exclusivity will only bring minimal revenue and is not going to significantly impact the return on investment. More recently, as was just discussed, the Limited Population Antimicrobial Drug Pathway, or LPAD, was passed as part of the 21st Century Cures Act. And this is for treating urgent medical needs that can be approved through clinical trials that have a smaller patient population, which should cut down on the time and expense of the trial for the developer. But this means that the drug will also only be available for use for a limited population of patients. So it further lessens the potential volume of use and potential revenue from the drug. There are other legislative proposals that have been put forward to try to encourage development of antibiotics. These include the Disarm Act, which would provide an add-on payment for antimicrobials that are administered as part of a DRG. There's the Revamp Act, which would give transferable market exclusivity to qualified products, which I'll talk a little bit more in the next slides. And then there's the Improving Access for Affordable Prescription Drugs Act, which included a prize fund for approval of innovative antimicrobial drugs. So all these proposals attack the problem in different ways, and each have their benefits and limitations, but none have made it very far in the legislative process. So there's still work to be done in this area. There are several executive efforts that have been going on concurrently to the legislative efforts. In 2014, the White House released the National Strategy for Combating Antibiotic-Resistant Bacteria, or CARB, which led to the formation of the group PAPCARB, who has released recommendations on all aspects of the AMR problem. For economic incentives, they recommended a combination of general and targeted incentives, including expanded R&D funding and implementation of a delinkage model. There have also been a couple of important public-private partnership initiatives that have been formed. One is CARB-X, which provides funds for projects in preclinical phases of development. And then there's BARDA, which has a program that supports companies through clinical development. And both of these organizations are important for helping companies get their product to the market. But without a predictable source of revenue upon approval, there will be limits to how successful any of these companies can be. So I just talked about some of the different programs that are meant to incentivize antibiotic development, and I wanted to show how these fit on the spectrum of a typical pipeline for drug development. There are essentially two main types of incentives. Push incentives, which are shown on the right side of this picture, focus on reducing the left side of this picture, that focus on reducing the R&D costs for new antimicrobials by providing financial and infrastructure support. And they can include things like NIH grant funding, tax credits for antimicrobial R&D. BARDA and CARB programs would be considered push incentives, as would the LPAD pathway. And then there are pull incentives, which reward manufacturers after an antimicrobial enters the market, increasing the potential revenue. And this can include the GAIN Act, the additional market exclusivity. It could be disarms add-on payments. And it also includes various delinking mechanisms, such as a market entry reward. And market entry rewards have been recommended by several groups, and essentially they provide a lump sum of money to an antibiotic manufacturer once the product has been approved, which removes the need for generating revenue through high sales. So the market entry reward is the favored delinkage model because a lot of the analyses by the other groups have looked at this, have shown that this type of reward would best reflect the public health benefits that these high-priority antimicrobials can bring. So a market entry reward would complement the early-stage support that is being provided through CARB and BARDA. Unfortunately, due to the very large dollar amount that is attached to this type of reward, and it's been estimated between $1 to $4 billion globally, funding this type of pull incentive is a major barrier to implementation. The other type of pull incentive that has been prioritized in the U.S. is the transferable exclusivity voucher. This mechanism would award to manufacturers who successfully develop an innovative antibiotic an additional 6 to 12 months of market exclusivity. But this exclusivity, unlike the GAIN Act, would be able to be transferred to a different or probably more profitable product that's in the company's portfolio, or the receiving company could sell their voucher to another company. So return on investment would be generated through sales of a different product or through proceeds of the sale of the exclusivity. This mechanism is attractive because it provides a financial incentive that does not rely on the volume of the antibiotic sold, and it does not require a large sum of money to be appropriated by Congress. However, a transferable exclusivity voucher would increase the price of a different drug by delaying the entry of generic options, and it does not necessarily directly address the issues with fee-for-service sale of antibiotics. So looking at some of the best qualities from these options, we want an incentive that is able to leverage existing antimicrobial payments to limit the need for public funding. We want them to limit increases in other drug prices and spending, and we want to reinforce the trend towards paying for value in healthcare. So when we first began this project at Duke-Margolis, we were interested in identifying pull incentives that would be most appropriate for the U.S., and we wanted to outline a feasible approach for implementation of this incentive. In order to do this, we engaged with a broad group of stakeholders that included manufacturers, payers, providers, government agencies, including support from the FDA, and patient representatives to identify and examine promising proposals and other potential models. Following our research and discussion with stakeholders, we arrived at several core principles, which I have listed here. And importantly, we wanted an incentive that could be a part of a comprehensive strategy of both push and pull incentives. We thought the incentive should provide developers with rapid access to funds upon market entry, that the incentive should align with broader shifts in payment away from volume to reward higher quality and value, and an incentive that would have public funding that would be complemented with private payments. So traditional fee-for-service payments are volume-based and do not support high-value and appropriate use of antibiotics. But there is an opportunity to bring the current payments for antibiotics in line with payment reforms that are current throughout the healthcare system. So in general, there's been a greater emphasis on value and quality in care delivery in the U.S. Many of these changes have been focused on provider care delivery and have taken the form of patient and episode-level alternative payment models. These models shift away from high volume and high intensity care by allowing more flexibility in how services are provided and providing higher payments for better measured results and lower overall costs. These alternative payment models also provide more support for care coordination and innovative delivery of care. However, they create more accountability for providers and can impact the incentives to use high-cost therapies that have a low impact on patient outcomes. So in essence, emphasizing quality and value in payment reform can create new opportunities and motivation for how drugs are reimbursed. And these concepts play into our recommended payment model for antibiotics. In our proposal, in order to qualify for the reward, an independent panel would set eligibility criteria that is aligned with current unmet medical need and would provide a list of desired R&D targets. Once a qualified drug has been approved, the manufacturer would receive award payments, and these payments would be delinked and would align with the global recommendations for AMR incentives, similar to the market entry award, and this amount would be paid out over a number of years. The payment that manufacturers receive for their drug would be a benchmark payment to reflect the innovation and value to public health in a tiered manner. And since the full reward amount would be paid out over a number of years, continued payments would be dependent on the availability of the drug, proper stewardship, and a transition to population-based APM contracts with payers. Our proposed model, which we are calling the Priority Antimicrobial Value and Entry Award, or PAVE, utilizes a phased-in approach to value-based reimbursement. So building upon the market entry reward, which would be given over the first few years of the model, manufacturers would be expected to transition to and engage in population-based payments for the antimicrobial with payers, which would supplant volume-based fee-for-service payments, continuing to delink revenues from the volume of drug used. Additionally, aligning payments with appropriate use would encourage all parties to support needed stewardship efforts. So key features of this model include a strong incentive for innovation due to predictable return on investment, changes to the structure of antimicrobial payments without significantly increasing the amount that is currently spent on antimicrobial drugs. There would be a combination of public and private funding to accomplish delinkage, as well as to support stewardship and drug availability. And it would provide a direct incentive to shift away from paying for antibiotics based on the volume used. So to illustrate how we envision this model to work, on the left side, this graph shows the proportion of revenue coming from various sources. And these numbers are illustrative, just to kind of give you an idea of how we envision this model working. The blue represents revenue from the market entry reward, the green represents fee-for-service revenue, and the yellow represents revenue from value-based payment contracts between the manufacturer and payers. So as you can see, in the first year or two, the majority of revenue will be coming from the market entry reward. But as time goes on, the manufacturer would begin to establish contracts with payers for population-based payments, and the proportion of revenue from this source would increase over time. This model still allows that some revenue can come from fee-for-service payments, but it will be far less than under the traditional payment models that we have today. So under our current payment system, all revenue is coming from fee-for-service. On the right side, this graph shows how a manufacturer could reach revenues of the recommended $1 billion. Again, the blue represents what would be coming from the market entry reward, while the green is fee-for-service and yellow is value-based contracts. The amount shown in yellow and green is a rough estimation of what antibiotic manufacturers might hope to make if their drug is commercially successful. So in the PAVE model, public funding from the market entry reward would supplement that amount. So there are still several outstanding issues and other considerations that will need to be worked out before any sort of implementation of this award. So there need to be some guardrails in place to ensure that value is delivered to all stakeholders. For example, payments for the antimicrobial would not just be given and not expect anything in return. The manufacturer would be expected to have continued data collection on the drug's use, as well as committing to the guaranteed availability of the drug. It will also be necessary for payers and providers to enact strong stewardship guidelines, which could include clear protocols for appropriate drug use and giving greater thought to how drugs are priced so that there's not an incentive to just reach for the cheap generic right away. We also need to consider that there might be some infections that are so infrequent that it may be more appropriate to consider a market entry reward only option because it might be, the drug itself might be used so infrequently that there's no incentive to do some contracting. Implementation will be dependent on measurement of value, which will need to be further defined. But the measures could build on those that are available today, including those that pertain to ongoing availability, utility, and access measures, as well as use data. We've also considered that initial payer participation could be challenging, particularly since long-term savings are difficult to account for with near-term payments. So implementation will require broad buy-in from the payer community. Also, antimicrobial use and how antimicrobials are paid for varies based on whether they are administered in the inpatient or the outpatient setting, and the guidelines and outcomes that govern the pay-reward model for these high-priority inpatient antimicrobials may need to be adjusted to be applicable within the outpatient setting. So I will stop there, and well, I'll be happy to take any questions at the end of the webinar. Thank you.
Thank you so much, Monika, for sharing your work. We're going to turn next to hear a little bit more about antibiotic stewardship efforts, and I'm pleased to introduce our next speaker, Dr. William Frese, who serves as the overseeing strategic medical director for Blue Cross and Blue Shield of Illinois' commercial and retail HMO quality improvement program. Dr. Frese?
Thank you, Catherine. Hello, everybody. I'm appreciative to be able to speak with you today about some key initiatives, Blue Cross Blue Shield nationally and Healthcare Service Corporation, which for those of you unfamiliar, manages the Blue Cross Blue Shield of Illinois, Texas, New Mexico, Oklahoma, and Montana plans, is doing in terms of some antibiotic stewardship initiatives regarding education, messaging, and some practice-based resources. So specifically what we're going to talk about today, I'm going to briefly introduce some of the Blue Cross Blue Shield national antibiotic prescribing reporting activities we have, and then we're going to move on to showcasing some of the HCFC specific provider educational practice support resources we've developed. Finally, we're going to wrap up highlighting some HCFC antibiotic prescribing provider feedback pilots. So to help serve as some context, I first wanted to share some key findings published by Blue Cross Blue Shield of Association, which is a national association that Blues companies like HCFC belong to. So back in August of 2017, the association released a 6-year trend report on national antibiotic prescribing among its Blue providers in outpatient settings. So some of the data I'm going to be reviewing with you is a little bit different, but overall consistent with some of the data you've already heard. And the good news was, as you can see from the title on the front cover, national antibiotic prescribing decreased about 9% nationally. But that said, consistent with some CDC data on the subject, there was also a notable national variation by state and metropolitan area in terms of prescribing. In Illinois, for example, although lower nationally, as you can see by the heat map on your screen, we experienced about a 3% increase in our prescribing patterns. Furthermore, there was a large Illinois metropolitan variability, with some areas and pockets within Illinois having prescribing as high as 36%. The report also noticed about 20% of prescribed antibiotics were not indicated, somewhat aligning with what you've already heard in other presenters. Primary care offices served as a large source for these trends, and there were some notable differences between adult and pediatric antibiotic prescribing patterns. So HCFC was already working on some initiatives to better support antibiotic stewardship, but these findings definitely helped further spur our own call to action. So I'm going to be talking about the remainder of what HCFC is doing in terms of various antibiotic stewardship initiatives. And developing these programs, we've tried to take an evidence-based approach with a multimodal approach that leverages multiple behavioral change theories in terms of education, motivational culture change, positive incentives to our provider, and of course providing some provider performance feedback. Additionally, it's notable to mention that the antibiotic stewardship is really just one component of these broader initiatives that also includes other clinical measures such as immunizations, asthma, diabetes, et cetera, that from a quality improvement perspective broadly work together for a consistent and complementary performance improvement approach. So to begin with, I'm going to show HCFC regularly includes some antibiotic stewardship topics into its Blue Review, our provider newsletter directed to medical group providers, leadership, and administrators. And marketing data has shown that the Blue Review actually has over a 60% regular clinician readership. So it's been an effective tool to consistently communicate to our 5-state provider network. We've done a few articles on the topic. On your screen are some snapshots of the antibiotic stewardship focus series we did back in December, highlighting some HCFC partnerships with the Choosing Wisely campaign, many of you are likely already familiar with, as well as more of an educational type article presenting some key CDC data to our network that also communicated updates on the antibiotic stewardship pilot I'm going to be speaking to you about later on. Continuing along the educational theme, we've also developed a set of best practices for clinical QI topics such as immunizations, asthma, diabetes, cancer screening, and of course antibiotic stewardship. These best practices act as a mini systematic review, if you will, offering a quick 2 to 3 page, easy to read review of current evidence-based initiatives that our busy providers can consider implementing to help boost practice-based performance. The best practices we're looking at now comes from our more general HEDIS tip sheet that has a focus on HEDIS-related antibiotic stewardship indicators, such as adults with acute bronchitis, children with viral URIs, et cetera. And it helps highlight some tactics such as watchful waiting and other approaches that we've identified there being an opportunity, especially for some of our adult providers who may be less familiar with some of these tactics, to incorporate into practice more consistently. The final educational resource we wanted to share is our quality improvement educational and toolkit database, which includes antibiotic stewardship topics by offering a more concrete blueprint of how to implement antibiotic stewardship programs. So on your screen now is an excerpt of the antibiotic toolkit with offered listings and by various respected stewards, a brief description of the educational components that are covered in the module, the link to access it, some notes of whether it's free or for charge, and then if any MOC credits are potentially offered that providers can help sort through. So by now you might be thinking that all the education is great, but how is HCFC actually helping to translate this into behavioral change amongst its provider network? So this is where some of our incentives, pay for performance, public reporting, and feedback programs come into play. The first being our HMO Quality Improvement Fund, with a program history that goes back to the late 70s, and it continues to have an influence among practice patterns today, even for non-HMO products, since these initiatives are typically implemented practice-wide amongst our network. The Quality Improvement Fund is a set of similar year-over-year consumer and clinical performance measures selected by the company, helps support broader healthcare performance, company and plan credentialing goals, and the performance benchmarks are statistically calculated from internal network and then national quality compass performance data. I have a subsequent slide that goes into this in more detail, but I wanted to first quickly highlight our Blue Star program as well, which is on this slide. And this is a publicly reported performance grading system of our 80-plus Illinois medical groups, for example, within Blue Cross Blue Shield of Illinois, that also has antibiotic stewardship performance data that feeds into it. And as we know, providers tend to be performance-driven, so this report helps providers cross-compare themselves, their medical groups, and it can also be viewed by patients publicly to help further drive performance in this area. So going back to our Quality Improvement Fund, though, on your screen currently are the 3 antibiotic-related HEDIS indicators that we have included within the fund, as well as their description. And for each of our providers, we'll do a random sample of provider-eligible patients. And as you can see on the screen there, they have 2 to 3 opportunities per indicator to achieve defined benchmarks with associated payment. And we've achieved considerable success with year-over-year increases thanks to this pay-for-performance program. And so on to our antibiotic stewardship pilot that leveraged claims data towards provider performance feedback. So this was an ecologic study with the goals to identify and provide feedback to HCFC's primary care providers with potentially high and inappropriate antibiotic prescribing behaviors. So how did we build it? The target population was 51,000 of HCFC's PPO and HMO commercial retail primary provider network, and it was then adjusted into specific state plan and provider specialty group cohorts with the assumption that there's a certain bell curve per specialty and perhaps per regional state area when it comes to antibiotic prescribing patterns. So overall, we analyzed 6 months of claim data for overall antibiotic prescribing, specifically for viral diagnoses, using the data code set from, again, those adults with bronchitis and children with URI indicators, which ideally many of you will recognize from a purist approach. There really should be no antibiotic prescribing at all. So again, our recognition flags here were somewhat liberal for this pilot. We also assessed utilization of what I'm going to term non-first-line antibiotics. So not necessarily looking for associations of amoxicillin prescriptions given with viral URIs, but really rather more broad-spectrum antibiotic classes such as quinolones and third-generation cephalosporins that really had no business being part of a viral-associated diagnosis. Again, trying to make this recognition of the extreme outlier providers relatively generous. And from this way, I identified the top 125 prescribing providers within each state out of, again, that baseline population of 51,000. So once we had this list of providers, in addition to the mentioned Blue Review article and some in-person messaging we did around this program at provider roundtable meetings, we then sent letters to these individual providers that basically re-explained the program. It provided the provider's total number of antibiotics prescribed compared to their specialty averages, and also provided some additional data regarding these identified non-first-line antibiotics compared to specialty averages. The letter also gave some Blue Cross Blue Shield contact information for questions and included a 5-question survey about the program, which I'll highlight some high-level results from on the subsequent slides. In addition to the individual provider outreach, we also noticed that we had 4 cluster medical groups, specifically within the state of Illinois, with a disproportionate number of providers, for which we thought it additionally beneficial to communicate to these groups the findings to their medical leadership. So as such, we sent letters to these groups' medical directors with the intent of provider feedback and maybe potential corrective action, for which we included the list of identified providers, the frequency and type of antibiotics prescribed by the provider, and individual encounter data. So to wrap up, what are some highlights that we learned from the pilot? Where do we plan to take it in the future? So for our successes, based upon some of the anecdotal and survey feedback we received from our providers, we felt the program successfully accomplished its goal of increasing potentially outlying prescribers for these behaviors. Somewhat surprisingly, a higher than expected percentage of providers told us that they found the feedback helpful and actually wanted to see some follow-up and some more detailed reporting to help change their behaviors. It also helped foster some new conversations around antibiotic stewardship between Blue Cross Blue Shield and our provider network. As far as opportunities go, we received a consistent feedback from our provider network, needs help and support from us as a payer with patient-direct antibiotic stewardship education, which, while there's patient-oriented approaches offered in the toolkit that providers themselves can implement, this program admittedly focused mainly on the provider network aspect. And so now we're considering what initiatives we can implement in this program's next wave that may assist with these efforts in terms of web-based resources, sending out educational materials with EOBs for suspected services and diagnoses as not needing antibiotics, et cetera. We also learned we needed to better help providers understand the program's measurement approach, generally receiving some comments that suggested that providers did not really understand how the project was conducted. which, although we did briefly explain in the letter, trying to balance out the goal of keeping the letter brief so a busy provider would actually read it, the detail provided was not enough. So we may have to bolster the next wave of letters with a website link or an additional attachment page that explains our approach in more detail. So like any study that uses claims-based data, missing diagnosis data for which an antibiotic may have been indicated may have skewed accurate provider identification. For example, for our non-first-line antibiotics, we saw tetracycline appear commonly. Perhaps this may have been for an acne ICD that just did not appear on the claims. The pilot also didn't really adjust for different prescribing patterns by different outpatient services, such as urgent care facilities versus primary care, where there may be a potential difference. So in addition to some of the considerations I already mentioned, where is the program headed in terms of next steps? For one, the program is going to graduate from a pilot to an ongoing surveillance program, which will be sending out a second wave of tiered feedback letters actually fairly soon, which is going to potentially identify new providers, of course, congratulate previously identified providers who have since rolled off the list, and for repeat providers, send second notifications. From a statistical approach standpoint, we're going to explore increasing the data measure timeframe to a full 12 months, may help eliminate some potential seasonal variation we saw, as well as segmenting out those urgent care facilities I mentioned, which, although, again, given the fairly liberal generousness of our selection criteria, I don't think it's going to have a significant impact. We did, again, receive consistent provider feedback that they felt this to be a cause of them being identified. So at the very least, we need to provide them with this data to address these concerns. And finally, we know we're not the only ones doing this. The CMS antibiotic surveillance program is a great comparative example. And so to better align our data with what providers may be seeing through this program, we're likely going to adopt some of their methodologic approaches in terms of minimal prescribing cutoffs for identified provider populations, which for part-time providers or retiring providers that may not be prescribing a lot may help shift that bell curve a little bit to the right. Although, again, identifying the top 125 out of 51,000 probably will not significantly change what we're seeing, but it will help align this criteria with these other programs to help make it more of an apples-to-apples comparison for our provider network. And I think we're going to hold questions until the end, so with that, I thank you for your time.
Thank you so much. We'll take questions in a couple minutes. We have two final speakers with us today, and we'll turn to talk a little bit about some consumer-facing education and opportunities on this topic. And our final speakers are Rick Young, who is a longtime Frontline producer. He also launched a production partnership between Frontline and the Investigative Reporting Workshop at the American University, and he's joined by Larry Kirkman, a professor of film and media arts in the School of Communication at American University and part of the Investigative Reporting Workshop. NIHCM Foundation provided journalism grant support for a project to educate the public on antimicrobial resistance, a project that was based on Rick's documentaries on this topic, including one called Hunting the Nightmare Bacteria, which also won NIHCM's Television and Radio Journalism Award back in 2014 and was recently revamped and re-released last year and also incorporated into Larry's project that we're going to hear a little bit more about today. So Rick and Larry, are you both with us?
Yes, I'm here.
Okay, we'll start with Rick. We're going to start with you.
Yeah, sure. Well, thanks for the opportunity. You know, I basically just want to. I know everybody's been at this for a little while, and probably a lot of questions out there. So I'm not going to take too much time, but wanted to just sort of offer more or less an observation about our projects and how we got into this. And this goes back about 6 years. So Some of this may be a little dated, but at the time, basically the issue, I don't think certainly resistance had quite the public profile that it does now. And we got into this really because David Hoffman, who was the correspondent on honey nut bear bacteria, had gone to the NIH, and this was not long after the outbreak at NIH had occurred, and he talked to them, and NIH, the folks there, the doctors, and the institution itself, was willing to actually sit down and talk about what happened there, which was pretty unusual. Their willingness to step out and publicly discuss an outbreak that had happened at the Institute. And so that was pretty much what got us started. But as we got into it, we immediately knew it, and this is a truism for journalism and certainly storytelling, that you need compelling characters, et cetera. So we went out to try and find stories to tell. And my observation here is that actually the most challenging part of this whole process for us in the films that we made was actually, and also the key to making the stories work, was getting access to hospitals in that case. And we had a lot of trouble. And I think, it's sort of understandable. Hospitals didn't want to talk about problems within their walls. But that was really the key, the fact that we were able to get some institutions to step forward. And I don't think it's coincidence that those institutions were research-based hospitals. The for-profit hospitals, we had absolutely no luck whatsoever in getting them to be willing to open up and talk about what was happening. And I don't know, I said, this was 6 years ago, and I haven't been back at it although we go back and update it, and we were in Houston at Houston Methodist. But I suspect the problem is still there, and I think that it wasn't just the ability of or willingness of and hard work of the infectious disease doctors that we were working with, but it was their ability to talk to and convince leadership at University of Arizona, at Harborview Medical out in Seattle, as I mentioned, Houston Methodist, for the leadership of those hospitals to decide, okay, we're going to trust you with this story. We know that it may have it can be abused in the sense of becoming a sensational story, and I'm not unaware of the role that the media plays in that. But I do think that, from our perspective, that was the key to actually getting the stories out there, getting the issue out there before the public, was the role that the leadership at the hospitals played in making that tough decision. And I think, going forward, that's frankly one of the barriers in getting the story in front of people is a willingness to step out there and say, hey, this is a problem that we've had here, but this is why it's so important. And that's going to take a mind shift, a bit of a mind shift away from seeing this as a marketing problem to, the medical emergency that it is and that the public needs to see. So as I said, I'm certainly aware of the role the media plays in maybe the reticence that's there, that these stories can be sensationalized, but we need to do a better job all around, and part of that better job is reaching people where they are, and that's not just through documentaries, which is why the work that Larry has done, I think, is so important, trying new approaches, keeping the work alive that we've done, and I'll throw it over to him. I'm obviously happy to answer any questions that people might have.
Thank you, Rick. These wonderful films really have made a great contribution to elevating the problems and solutions to AMR. We've used and built on Rick's two films, to create this interactive production. It was just launched last month, and it complements, in some ways, the work with providers, such as Dr. Frese described in the Blue Cross Blue Shield work, and focuses on reaching everyone, because everyone has a stake in understanding this crisis. And we believe it's our responsibility as communicators to inform and engage people at whatever their level of education or media consumption. As communicators, we make a lot of assumptions about the clarity of our language, about what it takes to interest people, to motivate them. And we need to ask the science communication questions on impact that are not often asked by journalists or filmmakers. What are people getting out of our media? How do we make the problems and solutions compelling? As Dr. Schneider said, the work we do can have a great impact on human overuse and behavior change. It can model provider-patient communication, and it can inform a wider public on the need for policy change and build public will for policy change, for funding for pharmaceuticals in the pipeline, and for standards for food animal farming as an example. We have to ask where people look for information. We did a survey, and 73% of our respondents said that they would look for information in online search, and in fact 12% of them said WebMD is where they would go first. 60% said that they would look to their health practitioners. So it's important that we have a multifaceted approach to communications on antibiotic resistance. We need to work on many fronts, from media relations and public service advertising to online resources, social media, to films and interactive media. The power of interactive is hey, where's my slide here? Okay, there we are. The power of interactive is that people can move at their own pace. They can follow prompts to get information. They can use a menu to jump from an individual story to a public policy issue to an explanation of the science. We found that they can be surprised by what they can know. You know, one of the assumptions we make is that empathy and fear are tremendous motivators, and that these personal stories that we feature, that come out of the two films and are put together as segments, you know, that have a strong story arc, that they will drive people to want to know more and pursue the issues that interest them. For example, as someone watches the frightening story of a young girl in the hospital with an infection that does not respond to any antibiotic, they want to know, what can I do to protect myself and my family? And they can follow a link directly to the CDC website, which has such a terrific and well-maintained section on protecting yourself and your family. The interactive gives the user the agency to move from these individual stories to public health solutions. They can go directly to a Pew story and explanation of what's in the pharmaceutical pipeline. They can go to a stat news animation on understanding the science. So it's our job to create a landscape of information and resources that people can tap into, to illustrate that, to demonstrate it, and to be, in a sense, a navigator for them, and to annotate it so that they know what they're getting and why. The four stories really allow people to find an entry point that will be meaningful to them. An 11-year-old girl gets a staph infection. Her mother asks, how did she get so sick? How did it happen so fast? It's the story of MRSA and a lung transplant. David, a young American volunteering in India, is injured in a train accident, has his leg amputated, and gets 5 antibiotic-resistant infections. He's brought back to the U.S. for treatment and brings with him the NIHCM Superbug. His doctor says we had nothing left to treat him with. These stories are enormously powerful. And then, as Rick said, there's a big focus on 2 leading hospitals desperately trying to contain the spread of superbugs, the National Institutes of Health and Texas Medical Center. These stories are tremendously motivating for people to want to know more, to know why resistance is growing. And what we found is that across class and educational lines, people did respond to the scale of the problem and the predictions of AMR overtaking cancer as the leading cause of death. They want to know more about the role of pharma and why for 30 years we haven't had a new antibiotic developed. They're interested in the fact that 70% of antibiotics important in human medicine are used in food animal farming. They want to know the role of government, the National Action Plan, the role of investing, new forms of public-private partnerships, and I think the role of public education to reduce overuse and the development of new standards and regulations. The explaining the science section we think is important, answering people's questions, and with the public health solutions to provide positive hope and to really give a sense of what's being done and what people can support. For example, the increase in antibiotic-free food through food companies, the role of restaurants and grocery chains, and what's happening there. So it's important as we go forward to develop this experimental communications model. We've used focus groups and surveys and user studies. What do people know? What more do they want to know? What does it take them to get interested? What are the barriers to sustaining their interest? What works and doesn't work with what audiences? We found that it's easy to get people concerned and interested and that they want to know more. First, information on their personal safety, what they can do to protect themselves and their family, and second, the potential impact of antibiotic resistance, how widespread the problem will be. There's a great challenge that we all face in engaging and informing the public, and it's important for us to work with partner organizations like those who presented in this webinar to shape our work going forward. So thank you.
Thank you, both Rick and Larry. And we really appreciate seeing how you've connected those powerful stories with additional resources and information. And I think was a link up that people can access the interactive and actually see how you can move through it. So we're excited now. We have a few minutes left to engage in a Q&A with our audience. So please continue to submit any questions in the Q&A box, and we'll get through a few in the next few minutes. And the speakers can come off of mute if you would like to address a few of the questions. So this question comes from Nandini Naran, who is in CalPERS in California. And she says antimicrobial prescriptions have definitely been driven up with the rise in use of urgent care centers, drive-through box clinics, and telemedicine. This has been shown in several published studies, particularly for UTIs and respiratory infections. How are aspects of unjustified prescribing, lack of ordering, relevant testing, lack of follow-up on results of testing all being addressed? Let's throw that out there. And Dr. Frese, I know you mentioned looking into the urgent care versus primary care issue, so I don't know if this is something you could speak to.
I can tangentially answer, for our PPO product, which was actually included as far as, our network study that we did. We also have, I didn't have time to go into it, but we have our accountable care organization, which is part of our provider network, where the providers are actually, there is similarly some antibiotic stewardship indicators included in that network as well. So in terms of our provider network that have urgent care sort of centers, et cetera, we are looking at those metrics. And then, of course, if they're achieving their benchmarks, there's potential for additional incentive payment. And if they are not, as is known for accountable care organizations, there's actually a potential for a payment penalty. So that would be one of the avenues that I think that we'd be addressing that with the PPO network, which is, a large percentage of our overall provider network.
Great. Does anyone else want to touch on the urgent care sort of telemedicine issue? We have a couple questions that came in for Dmitri. Are you still with us?
Yes, I am.
Okay. Two questions going back to your presentation, asking if you could talk a little bit more about the STIC website and when it was launched and plans for that, as well as a question about the full guidance for the LPAD initiative that you discussed, if it's been published or if not, when that will be available.
Right. I believe that I don't recall exactly the date. I think it was the AHT website was launched January, February. I mean, I think it was at the beginning. A couple of months ago. I mean, I would say.
Okay.
Times fly. I can check it as we speak. But LPAD guidance is under, I can say, under the clearance process. We have an elaborate process of clearance of the guidances. I hope it's going to be published soon. I cannot give you the date. It's kind of in the final stages from my perspective. But once again, it's been cleared by our FDA leadership. Hopefully, you will see it soon.
Okay, great. Another question that any of the speakers can jump in on, and Monika had a few pieces of this on her slide, but this question asks, what specific policies or regulations can we champion, either via communications to Congress or policymakers, or just to state and local leaders, or even in our local community, that can help address this issue and, slow the threat of superbugs, but also, help increase access to appropriate use of antibiotics?
So I can, sorry, go ahead. I can kind of touch on, I don't know that there, I think that one of the things, at least for legislators, is that individual, funding is always an issue that is helpful, either through NIH grants or through the BARDA and CARB-X programs. And I know that there are various groups who are working on specific policies that they are championing. But I think just overall, it's important that something gets done, and then it's really important that we are able to move something ahead forward. And I think that the community in general would back whatever policy would be most feasible to get through.
Hi, this is Alex. Go ahead.
Go ahead.
Okay, this is Alex Kallen. Just again to remind folks about the National Action Plan to combat antibiotic resistant bacteria. I mean, I think in there, a lot of the kind of framework that the federal government is working along to try and address not just stewardship, but the whole antibiotic resistance spectrum. Important to keep that in mind. And that's a really nice kind of One Health approach. It doesn't just address healthcare or stewardship. I mean, it really looks at across, the whole spectrum from the community, food supply, everything, healthcare, all under one area. I mean, one area that we're particularly interested in, I don't work on stewardship, but for the transmission of antibiotic resistance bacteria is kind of looking at some of these places where we're really seeing the amplification of these bacteria. A lot of times when we do these investigations, we see tons of transmission or amplification really for an entire region in some of these higher acuity, long-term, long-stay places, like post-acute care facilities. And, thinking, again, much work to be done on this, but thinking through how we can, improve the quality of infection control in those kinds of places and better do, surveillance and things like that in those kind of places. So that's something that we're working hard on at CDC.
It's Dmitri again. It's a follow-up to the question. Actually, the website was launched in December of 2017. I was off for a couple of months initially, so it was December 2017.
Great, thank you. So unfortunately, we are out of time for the Q&A, but do appreciate all of the excellent presentations today. We really had a wealth of information on this topic and really appreciate you all joining us to be with us. And we invite our audience to share any feedback from our event today by completing a brief survey, which can be found on the bottom of your screen. And we will be posting an archive of the event, and you can also access all of the slides on our website for additional information. So thank you all again so much for joining us today. We hope that you found it to be a useful webinar today.